Hi, my dear colleagues working in ICU, emergency, and anesthesia departments. I have created a structured video around the latest guidelines which have been published in last 2 or 3 years, which covers oxygen therapy, ventilator liberation, ARDS management, and precision ventilation. Before moving forward, let me ask you a question. Which of the following is the first line therapy for moderate acute hypoxemic respiratory failure? So there are options: A. Non-invasive ventilation, B. HFNO, C. Conventional oxygen mask, or D. Immediate intubation. You will get correct answer soon. Watch this video till the end. I am going to take three recent guidelines. The first one is SRLF SFMU 2024 Consensus Conference Guideline on Oxygen Therapy in Acute Hypoxemic Respiratory Failure. Because there is lack of standardized oxygen therapy in AHRF, so these guidelines were enacted. These recommendations clarify the role of conventional oxygen, HFNC, NIV, and escalation strategies. So, what are the key highlights from SRLF SFMU 2024 guidelines? The first one is that high flow nasal oxygen is preferred over standard oxygen therapy in moderate to severe hypoxemic respiratory failure because HFNO improves comfort, reduces the intubation rate. So that's the reason it is first line oxygen therapy. Non-invasive ventilation does have a limited role in treating pure hypoxemic respiratory failure due to the risk of delaying necessary intubation. So that is established, and this is why NIV should not be used in pure hypoxemic respiratory failure. The primary concerns are related to potential for unrecognized deterioration and delayed intubation. However, it has excellent role in cardiogenic pulmonary edema, where NIV, particularly continuous positive airway pressure, that is CPAP, or bilevel positive airway pressure, that is BiPAP, is first line therapy. So it has really good role in cardiogenic pulmonary edema. And also, NIV is the standard of care for acute exacerbation of chronic obstructive pulmonary disease resulting in hypercapnic respiratory failure. It improves ventilation, reduces the need for intubation, and also lowers the mortality rates. Third, very important point which I find is must to know is what should be escalation strategy. When to think of intubation in a patient who is on high flow or NIV. If your high flow nasal oxygen therapy or NIV do not work and patient deteriorates, guideline recommend early intubation. So use your clinical judgment. Look for persistent hypoxemia, high work of breathing, or hemodynamic instability in patients who are on HFNC or NIV to decide for early intubation. But don't delay the intubation because it carries highest mortality. Even in case of worsening mental status, changes in consciousness, or if the patient is agitated or lethargy, all these signs indicate severe hypoxemia or hypercapnia and the inability to protect airway. And in this regard, ROX index less than 3.85 at 6 hours after initiating high flow nasal cannula is an indicator for a high likelihood of treatment failure and requirement of early intubation. So this is a strong recommendation. Use ROX index in such patients who are on high flow. And you know what a ROX is. So it has been popularized, and it is very important to know about ROX index. So ROX is basically SpO2 upon FiO2 upon respiratory rate. If ROX index after 6 hours of application of HFNC is less than 3.85, the patient is at risk of treatment failure and early intubation should be strongly considered. Finally, do not over-oxygenate. SRLF guidelines suggest target saturation between 92 to 96%. Don't target 98 or 100% of saturation. The key reason for avoiding over-oxygenation is that hyperoxia does not offer additional clinical benefit and may potentially cause harm such as increasing oxidative stress, causing coronary vasoconstriction, and potentially impairing the body's natural respiratory drive in patients such as COPD. Now, the second guideline which I am going to take is the 2024 American Association for Respiratory Care AARC Clinical Practice Guideline for Spontaneous Breathing Trial and Ventilator Liberation. So for SBT and ventilator liberation, these guidelines should be followed, which are the latest in this section. The reason for these guidelines development was inconsistent weaning protocols among intensive care staff, which was translating to delayed extubation. This is the main problem. You put the tube in, you put the patient on ventilator, but when it is about weaning, I think everybody is struggling. The clinicians, the nurses, and the patient itself. And the family is asking when my patient is going to come out of ventilator. So this is where the more research is required. This is where more monitoring is required, and that's how we are going to change the outcome. Anyway, the first and foremost recommendation from AARC guideline, which has been a surprise to me, that rapid shallow breathing index is not required to determine the readiness for SBT. As you know, we were using RSBI since last, I think, 15 years. And while RSBI can still be a data point, a specific cutoff, that is less than 105, is no longer a mandatory requirement. The guidelines promote using a set of clinical criteria that indicate the underlying cause of respiratory failure has resolved and the patient is stable enough to attempt breathing without full mechanical support. So clinical judgment is more important than, particular index like RSBI. So that's not required anymore as a single criteria. Use the set of clinical criteria to judge the readiness to wean and extubate the patient. Now, standardizing the timing and the process of SBT is the second major pillar of this new recommendations from AARC guideline, which suggest performing the readiness assessment and SBT early in the day, ideally before 12 p.m. This timing coordinates effectively with the morning rounds, daily sedation interruptions, and other standard morning care bundles such as ABCDEF bundle for ICU liberation. ABCDEF bundle is very, very important. Every ICU should practice it. So we are not going to talk about that. Remember, don't delay your SBT and perform SBT every day. Once patient is recovering from critical illness and off sedation, every day you should assess SBT, don't delay it. Every hour counts in ICU. The AARC guidelines offer clear recommendations on acceptable modes or methods for performing a spontaneous breathing trial. So there is nothing called a single method or the single best method of SBT conduction. You can use either TPs or CPAP or low level of pressure support ventilation, anything. So if you are using low level of pressure support, you can use between 5 to 8 centimeter of water compared to 10 to 12 centimeter of water. Now they have reduced the pressure support level for SBT. So don't use like 10 or 12. Use little less, 5 to 8 centimeter of water of pressure support. The SBT, and use PEEP of 5 centimeters. So this is a new lower value, and this is a gentle approach that may take the SBT feel more comfortable for some patients. The key takeaway is that the major clinical studies have not consistently shown one method to be significantly superior to the others in terms of overall successful extubation rates. So the best method is, depending upon your local clinical practice, the specific equipment available, and the individual patient tolerance. Guidelines recommend against increasing FiO2 during SBT and suggest to maintain same level of pressure support ventilation and FiO2. So if a patient is struggling to oxygenate adequately, their SpO2 might drop during the trial. So the nursing team or clinical team or RT, respiratory therapist, should not increase the FiO2 at all in this situation, or should not increase the pressure support. Rather, should terminate the SBT, the spontaneous breathing trial, in this scenario and documented that SBT is failed. However, if you try to increase the FiO2 or pressure support in this situation, it potentially masks the weaning failure and can lead to false positive SBT results and premature extubation. Okay, so that's very dangerous. It's not recommended. Now we will move on to third guideline, which is extremely important to read by all the intensivists. So this is the ESICM 2023 ARDS guidelines published in ICM, and these are crucial document for all clinicians managing critically ill patients. So they consolidate the latest evidence to provide strong actionable recommendations on mechanical ventilation strategies and adjunctive treatments. As you know, the guideline reiterate a strong commitment to keeping pressures and volumes low to prevent ventilator-induced lung injury. So that is the first and foremost goal of this guideline, to minimize the VILI, specifically valve trauma and barotrauma. So a strong recommendation is to ventilate all adult ARDS patients using low tidal volume, that is 4 to 8 ml per kg of predicted body weight. Historically, ARDS has been treated as a single uniform disease process. However, recent research has revealed significant biological heterogeneity among patients with the syndrome. So as you know, this is acknowledging the variability in patients, and these are the first major international guideline to formally integrate the concept of ARDS subphenotypes into management recommendations, moving the field of respiratory critical care towards precision medicine. So precision mechanical ventilation refers to tailoring ventilator settings to individual patients' physiology, lung mechanics, and ARDS subphenotypes, rather than applying one size fits all protocol. So you need to select the patients, and you have to recognize that there are two types of ARDS subphenotypes, and accordingly you need to change the tidal volume settings and select the PEEP. And while you are selecting the PEEP, you can use lung ultrasound or electrical impedance tomography or CT scan. So there are various things which you can do, and a lot of inputs from the patients you can use to decide or customize the mechanical ventilator settings. Okay, so don't use the same ventilator settings for everyone. It's not like low tidal volume is always good for everybody. You can use a little higher as well. Okay, so depends on your patient population. Apply higher PEEP in moderate to severe ARDS and titrate based on oxygenation and compliance. And there is one thing which they always say is to measure the driving pressure and keep it less than 15 centimeter of water. Okay, so that's very important. This is emphasized in these guidelines. And recruitment maneuver. So these are not totally abundant, so you can use recruitment maneuver only in the refractory hypoxemia with caution for hemodynamic instability. And there is more impetus given on prone positioning. Okay, it's strongly recommended for PF ratio less than 150, and each session should be more than 16 hours to improve the survival. These guidelines also provide a strong recommendation for the use of VV ECMO as a rescue therapy for severely hypoxemic patient. So if the patient has severe hypoxemia, say less than 80, PF ratio less than 80, definitely you should go for VV ECMO. And also you can use extracorporeal carbon dioxide removal devices. So this is the comparative summary table for to compare these three important guidelines on oxygen therapy, ventilator liberation, and ARDS management. Okay, so this is just finished. And artificial intelligence and machine learning models, a lot of research is going on these two important new technologies which show significant promise in predicting mechanical ventilation, weaning, and extubation process even in complex cases like ARDS. And these models, machine learning and artificial intelligence, outperform traditional methods. And there are several ongoing studies and clinical trials actively researching the integration of biomarkers and imaging for ARDS phenotyping and guiding therapy. The field is actively moving towards validation of findings from previous retrospective analysis. So this is what the current generation is doing. They are validating all the previously held conceptions and guidance, and whatever we have read in our intensive care books, we are going to validate all of them, one by one. This is what we are going to do. And our next generation, and the next generation is going to do the same and even improve on that. And I'm very sure that next 20 30 years of critical care medicine and how we practice is going to be very exciting and going to open new horizons. These are the few references. Thank you so much for your attention. Bye bye.